Welcome, I'm the dentist. In our DENTAGENDA, we will be continuing the first chapter, History Taking and Examination, the other half of the Part 6 Differential Diagnosis. These are the points discussed in this video series. And here is the detailed content. In this tutorial, we will be handling the second part of differential diagnosis and treatment planning. The source of non-odontogenic pain can arise from any anatomical structure of the orofacial region. As dentists, once we realize that the pain is not reproducible and there is no evidence to make a dental diagnosis, we find ourselves out of our comfort zone and everything starts to look a bit vague. If the symptoms cannot be reproduced in the tooth, there is no dental treatment that can result in pain relief for the patient. There are many conditions of craniofacial origin that mimic toothache and should be considered in differential diagnosis. If dental etiology is eliminated, referral to the proper specialist will be better than telling your patient you have no idea what is causing the pain. Only the most common syndromes that can cause non-odontogenic pain will be discussed in this tutorial. The first cause for non-odontogenic pain could be muscular. Muscular pain frequently occurs concurrently with a true toothache. The symptoms are often disguised as odontogenic. So the patient seeks dental treatment. Once the dental pain is treated, the mask comes off and the true nature of the muscular component is revealed. And the patient revisits confused about the pain. Muscular pain symptoms are characterized by a deep dull ache, sometimes with occasional sharp lancinating pains in the ear, temple, or face. Included in this group are myospasm, myositis, local myalgia, fibromyalgia, and myofascial pain syndrome. Myofascial pain syndrome is characterized by trigger points in the muscles that, when stimulated, they refer the pain to other areas in the same region, frequently felt and described as knots. These trigger points are actually weakening the muscle, limit the range of motion, and cause stiffness and tenderness to palpation. Trigger points are common in all parts of the body, but the muscles of mastication are prime targets for myofascial pain syndrome, particularly in patients with parafunctional habits, and it is most prevalent cause for temporomandibular joint disorders. When the muscular trigger points are stimulated, pain can be referred to the teeth as follows. Starting with the trigger points in the temporalis muscle. It is the largest muscle of mastication. When the pain is referred from the most anterior part of the muscle, it can cause deep, dull, aching pain in the maxillary anterior teeth, into the temples and temporomandibular joint, and over the eyebrow. As the trigger points progress posterior and superior, the pain will refer backwards toward the maxillary premolars and molar teeth. Then we will talk about the trigger points in the masseter muscle. When the trigger points are stimulated, pain can refer to the maxillary and mandibular molars, the superficial and deep layers of the mandible, as well as the TMJ and the ear. Digastric muscle trigger points. When the trigger points are stimulated, the pain refers to the lower anterior teeth, particularly lower incisors. Another common head and neck referral pattern is from the sternocleidomastoid muscle to the periorbital area and may be felt in the ipsilateral canine. To diagnose and temporarily treat the myofascial pain that results from the muscles, the use of some neurotoxins like Botox can be used to distinguish between the dental pain and the muscular pain, just like the use of the dental anesthesia. But it is not a permanent treatment. This picture shows the trigger points in the patient with a significant hypertrophy of the masseter muscle, and this other picture shows the injection sites of the neurotoxins in the masseter. In this picture, it shows the injection of the neurotoxins in the trigger points of the temporalis muscles. So, to sum things up, to differentiate between odontogenic and non-odontogenic pain, if you use dental anesthesia and the pain is relieved, then you will know that the origin of the pain was odontogenic from that teeth. And if you used a muscle neurotoxin and the pain was relieved, you will know that the origin of the pain was non-odontogenic. Second cause of non-odontogenic pain is temporomandibular joint. We ask ourselves, which comes first, the myofascial pain syndrome or the temporomandibular joint disorder? The truth is that they are both subcategories of the same musculoskeletal disorders. Factors such as stress, hypermobility, parafunctional habits, developmental anomalies, any disc derangement or movement, and internal resorption can all cause temporomandibular joint disorders. Characteristic findings include joint clicking and crepitus, deviation upon opening, limited range of motion, and dislocation of the mandible. The patient will complain of dull ache that worsens by chewing or opening wide. This is frequently exacerbated by parafunctional habits, and patients commonly seek emergency dental treatments. Third cause of non-odontogenic pain could be neurologic. Neuropathic pains are caused by any pathosis or structural abnormalities affecting the peripheral nerves. While toothache pain is described as localized, intense, dull and throbbing pain, neuropathic pain presents as burning, tingling, stinging, electrical, piercing, cutting, or drilling pain. Once any form of neuropathy is diagnosed, referral to neurologist is advised. The first form of neuralgia we're going to discuss is the trigeminal neuralgia. The trigeminal nerve is the fifth cranial nerve. Patient can report deep and lancinating pain. A trigger point as small as 2 mm is present in the facial skin or in the oral cavity and occasionally in specific tooth. The pain nature is quick in onset and short duration. Because it radiates to the bone and teeth, it can be confused with pain of pulpal origin. But the electrical nature of this pain can distinct the trigger point and differentiate it from the dental infection. Also, the post-hepatic neuralgia. It is manifested in the head and neck area, when the trigeminal ganglion harbors the latent varicella-zoster virus. It is characterized by a vascular eruption on the entire sensory nerve pathway. As is common with other neuropathic disorders, the pain is described as burning, stabbing, and electrical. It can also be confused with the pain of the pulpal origin because the patient will describe sensitivity to touch and temperature changes, but this will not be dentally reproducible. If the ninth cranial nerve is affected, that will be glossopharyngeal neuralgia. It is caused by an irritation to the glossopharyngeal nerve. It can be confused with dental pain because the symptoms are elected during chewing, swallowing, coughing, laughing, and speaking, mostly in the throat area. Fourth reason for non-odontogenic pain is neurovascular and vascular disorders. The patient history can be misleading because some treatments seem to randomly reduce the patient's symptoms for a period of time, or the initiating factor took place many years prior to the first episode of pain. Atypical odontalgia, or the unusual dental pain, has symptoms similar to pulpitis as well, yet there is no reproducible evidence for the pathology. Invariably, if endodontic therapy is performed, the procedure will not relieve the patient's pain. Many times, the patients can be present with several endodontically treated teeth or even an edentulous space as a result of multiple dental procedures performed by clinicians unfamiliar with this conundrum. Patient will report temporary relief from the pain after dental procedure, with subsequent return of the symptoms that can complicate the diagnosis even further. Neuralgia. Inducing a cavitational necrosis or ischemic necrosis is most often identified in areas of failed root canals, previous extraction sites, sinus infection perforation into the maxilla. The pain along the nerve course described as throbbing or burning pain. It is referred from the maxilla or mandible and occur in the face, behind the eye, and the top sides of the head. The diagnosis is complicated when the pain occurs many years later after the initial trauma to the bone. Cluster headaches that occur in the form of pain episodes that lasts for days or months, interspersed with pain-free periods, usually limited to one side of the face. This syndrome can also be mistaken for pain in the maxillary posterior teeth. Temporal arteritis or giant cell arteritis. Temporal arteritis is a form of vasculitis or inflammation of the blood vessels in the temporal arteries. This case is quite rare. However, it's noteworthy because blindness is a serious potential complication. If the patient reports any transient vision loss, immediate referral is vital. It can easily be mistaken for TMJ dysfunction, myofascial pain syndrome, acute alveolar abscess of the molar teeth, or sinusitis. The pain is localized to the anatomic area of the artery, but may radiate down to the ear and teeth. It is usually unilateral and will frequently cause scalp tenderness in the ipsilateral occipital area. Sixth cause for non-odontogenic pain is salivary glands. Sialolithiasis is caused by the accumulation of calcium phosphate salts that form a stone in the salivary gland duct. When the stone becomes larger enough to occlude the duct, inflammation and pain are the result. This phenomenon is most common in submandibular duct, leading to swelling of the gland, hence mimicking the infection of a posterior mandibular tooth. It can be reproduced when a patient sucks a lemon to stimulate salivation. When the parotid gland is blocked by its stone, that case is called parotitis, as in this picture here, and it can be confused with odontogenic pain, TMD, and myofascial pain syndrome. This X-ray shows an occlusal view of the lower arch, and here is a stone in the submandibular ducts. Also, it's a lateral view, and it shows the same stone. Sialography, or the radiosialography, is the radiographic examination of the salivary glands, or specifically salivary gland ducts. It is usually involved the injection of a small amount of contrast medium to appear radio-opaque in the regular X-ray. And then you can see here that the resulting image is called sialogram. This first picture on the left shows a normal ducts because the contrast medium follows the pathway of the duct and its branches. In the middle picture, you can see that the contrast medium stops in here, and the other branches are not vividly appearing, which means that there is a blockage here. In the third picture, the duct is full with a contrast medium, and there is a radiolucent body, which is the stone in this case. But it does not block the whole lumen, and that's why the contrast medium could pass to the other side. Seventh cause is the ear and nose. Sufferers from any ear or nose infection are so familiar with the symptoms for these diseases. They rarely seek medical care and tend to self-medicate with over-the-counter discongestants and antihistamines, as well as antibiotics left over from the last time. Otitis media, or the middle ear infection, is common particularly in children and caused by biogenic bacteria. It may be confused with a dental infection because pain can be referred to the posterior teeth as well as to the posterior mandible and maxilla. Once dental infection and TMD are ruled out, referral to an otolaryngologist is advised. Acute maxillary sinusitis, or acute allergic sinusitis. Can cause an actual tooth pain in the maxillary teeth, particularly when the roots of the posterior teeth extending near the antrum or inside the antrum itself. When the fluid pressure caused by the infection or inflammation builds up inside the antrum, the patient will experience bilateral tenderness on the cheekbone upon examination, facial swelling, throbbing headaches, fatigues, runny nose, and also increased pain when the head is tilted downwards. It rarely involves just one tooth and should be suspected when multiple posterior teeth are positive to biting or percussion tests. It is possible that an acute alveolar infection can spread into the sinus, thereby creating an acute bacterial sinusitis. If the sinus is treated without the elimination of the dental source, the sinus infection will reoccur. Ninth cause for non-odontogenic pain is cardiogenic. Many heart attack symptoms go unrecognized. The most common is which mistaken for indigestion, while the chest pain and the pressure is pathognomonic to the patient may experience left jaw pain, toothache, and headache. While the pain from a toothache could be described as throbbing or aching, pain of cardiac origin is described as pressure or burning. When the pain occurs after exertion, cardiogenic etiology should be suspected. If patients are experiencing a cardiogenic toothache, give them an aspirin and make sure they go to a hospital emergency room immediately. Iatrogenic causes for non-odontogenic pain. Iatrogenic etiology must be considered in the differential diagnosis of pain. It can be related to a present illness caused by a medical examination or recent treatment or surgical procedure that consequently causes pain, and the pain is definitely not related to teeth. The last cause for non-odontogenic pain that will be discussed in this tutorial is neoplasm. Neoplasms in the jaws are rarely painful and even more rarely encountered. A patient with this unfortunate disease can present with unusual symptoms like pain that resembles pulpal pain and then will relieve suddenly and disappear, and then they will experience tooth mobility. And when the dentist will hear all of these complaints and make a routine X-ray, panoramic or CT, the neoplasm will show. It should be examined using radiographic examination aids and biopsy. In summary, a variety of pain disorders involve the head, neck, jaws, and face. Many contradicting symptoms may exist when a patient presents with multiple problems. In order to diagnose and treat dental diseases, a thorough understanding of both odontogenic and non-odontogenic etiologies of tooth pain is paramount. To become a successful diagnostician, one needs to have interest, intuition, curiosity, and patience, and a quest for knowledge. Each day presents a new opportunity, and it's your choice at the end. And here is a reminder from Harvey Mackey. For further readings, please check these links. They will be listed down in the description box. For further readings in oral lesions, check these links. Thank you. Don't forget to subscribe and join us on Instagram at DENTAGENDA.